policies in India during the COVID-19 pandemic. I'm going to share my screen. 1 second, let me know if it's visible to everyone. One more. Yeah, share screen. I hope I'm visible. My screen is visible to everyone.
Yes, yes.
Thank you so much for confirmation. Right. Okay. Yeah. So I will be talking about. Yeah. I have made it full screen. I hope it is full screen for everyone. Okay. So
Yes.
I'm going to talk about the data-driven disease modeling and how it has shaped the policy in India, specifically over a last decade or more than a decade, if I would say, in the TB tuberculosis control program. As we all know that tuberculosis is the deadly disease, and India is one of the high burden country, along with some of the African countries. And we have been designing our policy by generating the evidence through the modeling, not just only the empirical studies that has been taking place, but yeah, else. So moving forward, so just before I start with the way I have laid down my talk for today is I'm going to talk about the how the modeling has shaped or generated the evidence for tuberculosis control strategies. And then because this has been disease modeling has played a vital role for more than a decade, as I said. And thereafter, how in COVID-19 during the pandemic, how along with other global countries, India was also considering the evidence generated from the modeling of COVID-19 in India, and how it has shaped the control and mitigation strategies in India. And thereafter, I'm going to just show you one of the quick example of not just the modeling, sometimes the quick epi analysis, the analysis of the epidemiological data could really be beneficial or helpful for, um, giving you the insight in really changing outbreak scenario like COVID-19, and of course any other outbreak scenario of say H1N1 or etc. Starting with this work. Well, this work, so for this talk, I have not just captured my work, but also some of the leading work that has shaped policies in India from other researchers as well. So this work by Professor Megan Murray from Harvard and Olivia. This was on the tuberculosis and poverty. Now, when we do the modeling analysis, the thrust is not generating the evidence, but also it is well taken up by the policymakers, by the program people. So it is important to hit the right point. Now, in the initial years, I would say that, I mean, when there are policymakers, they are not aware of the modeling and how should we go along with them to say that the evidence generated from modeling is really helpful and could be crucial for designing and implementing the control mitigation strategies for any given disease. So poverty is one of the things where most of the government are interested in bringing it down. Thus, this specific research work, focused on how modeling could be used for advocacy purpose also. And here in this work, they took the example of tuberculosis and trying to see where the tuberculosis burden is actually standing in terms of the wealth quantile. Is it the tuberculosis mostly with the people from the low economic strata, or is it spread across the economic strata? And from this work, they said that and this was based on the self-reported TB prevalence back in 2011, 2010. So you can see that this graph really shows that the TB prevalence, if plotted by wealth quantile, is suggestive of that high burden exists among the poorest population. And as the economic status increases, and as the socio-economic status of the families of the individuals increases, the chance of or the prevalence of tuberculosis also decline. And why this was the need of the hour? Because health does not remain the priority for many of the governments. And in India specifically, the way the health is, it is the matter of the state governments. It's not the matter of the central government. So majority of the times, the governments are much more interested in bringing down the poverty, in reducing the poverty, rather than looking at the health. This was a scenario I'm talking about more than a decade ago. However, this has changed over a period. Uh, but this suggested that health can shock the poverty, or it's linked. The poverty and the health is linked. If you increase the economic status of the population, of the public, it would also increase the health of the people. Or vice versa, if the health of the people is increased, it's better, then the poverty could decline. And why is it so? Because it has a potential to improve the socioeconomic, um, structure of the. So if person is healthy, they are able to go to their work, and there will be no loss of wages. However, if an individual is suffering for a very long time, there will be loss of wage, and there will be decline in the economic economic situation of the family. So both are linked. So yeah, moving to the next is I hope everybody knows about Gene Expert. Gene Expert is one of the microbiological. It's a diagnostic tool for diagnosing the tuberculosis, and these Gene Expert machine are basically they do some DNA analysis, and within 3 to 4 hours they gives the result whether the specimen, the TB sputum specimen is TB positive. Sorry, an sputum specimen of a given individual is actually TB positive or not. And in certain cases, it also gives the not in certain cases, but it also tells you about the rifampicin resistance. Which is one of the important drug resistant category for tuberculosis, and it is important. So during early times when Gene Expert was manufactured, it was way back in early 2010, 2012, 13, and it was made available in India. But these were very costly machines, and government had to think very carefully where we should roll out these Gene Expert. What will be the impact of rolling out these Gene Expert machine for diagnosis? In India, the healthcare system is bifurcated, and it is the government hospitals, clinics, and then there is another um, uh, um, healthcare system which is governed by the private bodies, private hospitals, you would say, or the even private practitioners, which are there available for the treatment. So this is something which is very important, and which was very crucial to know whether the rollout of these Gene Expert machine in the government facilities would be really helpful or beneficial in making the substantial impact in reducing the tuberculosis burden, as well as the DSTB, drug susceptible TB, or the MDR-TB. But how do we know it, right? And even rolling out the 100 gene expert machine, this was something like one test used to cost uh, around about 1,000 Indian rupees back then, or maybe more than that. So, and these gene expert machine also required the controlled environment in terms of the temperature. Low temperature was necessary, which means the other logistic needs were to be taken care when these gene expert machines are being made available in any healthcare facilities, whether it's private hospitals or the public or the government hospitals. So this was happening with the help of the government funding. Government had to decide where should we put the money in, where these resource allocation should happen. So again, the modelers try to understand what is the how the implementation strategy should be, and how should we scale up these gene expert machine. Say for example, if 100 gene expert machines are being rolled out in certain sector, whether it should be in combination public and private both, or whether it's in just government hospitals or in the public hospital, what it should be for the best. So this work led to understanding that if the 100 gene expert machine is rolled out in the private sectors, that means the healthcare facilities governed by the private entities, private hospitals. You may have heard about the big hospitals and all. So if it is given to those hospitals, because there was a lot of TB, presumptive TB cases were actually going to for the diagnosis primarily in the private hospitals because of the availability in the nearby area, or whatever reason, rather than simply rolling out them into the government hospitals. So what happened was when this modeling study came out, and it showed that if we roll out the 100 expert system in so, and this is the some scenario analysis where the if it is rolled out in public sector and only for detection of MDR TB risk, then there is the very small, sig impact of it will happen in reducing the TB burden eventually in the coming years. If it was rolled out in all the public sectors for whether it's a MDR case or the TB or DSTB case, for all the cases, it may have the significantly increased impact, but the highest impact was seen if the rollout happened, or if these 100 gene expert machines were made available in the private sectors hospital. Provided that because these are only the diagnostic tool, it was also important to maintain the treatment success rate, because for the drug susceptible TB, it's a 6 months of treatment, and back then for the even for the MDR or DR TB cases, the treatment was for 2 years long. So there was a lot of chance of people dropping out of the during the course of treatment. So it was also necessary that an individual who has been diagnosed with the TB complete their treatment. And if at the population level, if the 95% success is achieved in completing the treatment, then the most or the greater impact was of rolling out these machines in the private sector was happening. if it is also good to see that if you compare that rolling out of these machines in the private sector only, but if the treatment success rate is at 75%, just 20% below, right? The loss of reduction in the TB burden in the coming years was way, way, way small. So from 1.7% of reduction to the 0.3% of reduction only. And so this was also important that just rolling out of these machines are not good enough. We have to maintain the treatment success rate at 95% to achieve the um, uh, mm, higher epidemiological benefit. Um, it was so just so if it in the case of DSTB it was the highest, and also if in the case of MDR TB cases, rolling out in the private sector was much more in the government sector was much more beneficial in epidemiological terms. So this kind of studies, research work helps in also fueling the future research work. When this research work happened and it showed that generated the evidence that these gene expert machine what they can do, you know, then it was seen that you know that we should also fuel our research in the what you will say um, uh, uh, you know the future research should also be focused on developing the indigenous machines for diagnosing these gene expert machines. Previous to gene expert machines, the diagnosis test was either the sputum specimen testing, which was quick, but there was a higher chance of false positive cases. Secondly, there was this culture test, but it took 1 month to 3 months to tell whether the person have confirmatory TB or if there is a drug resistance variant, of TB. So availability of these machines help to reduce the delay in diagnosis. So this work said that there needs to be a research fund which is made available for the future um, development of the indigenous machines which microbiologically or with the sputum analysis can tell quickly within hours, and also given the climatic condition of India, these gene expert machine required uh, mm, the low temperature. So maintenance or logistics was one of the problem. So we wanted something which is actually we do not have to care about the low temperature, maintaining the low temperature, and it helped in uh, uh, development of our indigenous uh, diagnostic tool, which is known as TrueNet. Um, Mm, so prior to the development of TrueNet, there was another study came out, which was again on the deployment of these gene expert machine in the public sector, and this time was on the basis of the access. So what is the excess of how much access is there to the given population to these healthcare facilities? If it was 20, so here you can see that all TB cases and MDR TB cases. So all TB cases is whether they are drug susceptible TB, DSTB, or the MDR risk patients. So if it was 25% access, 50%. So again, this is a scenario analysis using the modeling. And here it was seen that what was the cumulative number of cases which can be averted by providing or by deploying the um, uh, gene expert machine in the public sector. And if the access is actually high, even if it is somewhere around the 75%, it is actually reducing the very good number of MDR TB cases. So nearly about 3.5 into 10 to power 5. So something around 35,000 cases, or yeah, cases were averted during 20, could be averted from 2015 to 2025. However, for the drug susceptible TB cases, the impact was much more higher. This is the reason being, in India, the proportion of MDR cases were around 4%. Now it is again 4 to 7% only of the total TB cases. So majority of the TB cases are generally the drug susceptible TB cases. However, since the proportion was is small of MDR cases, so given access, the cumulative number of cases that could be averted with the diagnosis, and assuming that when the access is made, there is the treatment success rate is constant, it's high. And so in over mm, so this deployment was not happening in just one go. It was over the time period of 3 years, and yeah, so that was it. So this is the showed, and with these evidence coming through the modeling, the TB program, national TB. So back then it was a revised National Tuberculosis Control Program, RNTCP, which laid down the policy for deploying the gene expert machine in the public and private sectors, which was made available with the government subsidy, and even in the private sector. And also a new research was fueled to make indigenous uh, diagnostic tools similar to Gene Expert, which came out as a TrueNet, and this also reduced the cost of the diagnostic test, with the same characteristic. That means within 3 to 4 hours of the sample, the results were given. And those results were with high accuracy, whether it's a drug susceptible or drug resistance TB, both could be tested, and result can show this within 3 to 4 hours itself, without taking care of the logistic in terms of the maintaining low temperature. And now, in the early 2000s, as I said, that India is having the bifurcated healthcare system, public and private. So whosoever was seeking care in the in the public sector, that means the government hospitals, they were notified. However, those who were seeking care in the private hospital, they were not notified. So there was very difficult situation because there was around about 1/3 of the actual TB cases were missing from the notification data, which was a serious problem. And why this was a serious problem? Until unless you have accurate data showing what is the status or what is the current burden of TB or the prevalence of TB, one cannot assess how much is achieved through the existing policies, the interventions, or what next we need to do in order to reduce the burden further. So having the clear picture or assessment of where the TB burden stands as of today was very important, and knowing um, how much individuals or how many individuals are seeking care in the private sector hospitals was very, very important. And in order to know this, how one can identify or estimate this missing numbers. So we thought a lot about it, and this was actually work of one of my group member, Professor Niman Arunamintati, and we collaborated with the IMS and for the TB drugs that the you know so as per the WHO protocol, there is a certain number of drugs which are given for the um, which are first line drugs actually, which are given to the government hospital, and every patient will have their own box for a month, and from that box the medicine was used to be given to the patient who used to visit the healthcare facility every day or every alternate day. But in the private sector, that was not the case. It was since it was not governed by the government protocol. The doctors were prescribing the medicine, of course, from the available first line, second line, third line, whatsoever, depending upon the status of TB, whether it's a drug susceptible or drug resistant TB. We try to procure the data of TB drugs sales, and in order to estimate the tuberculosis burden in the private hospital in India. In And for this, we tried to see the we tried to estimate the volume of or volume in terms of the patient months of treatment, and this was not a transmission dynamics type of modeling. It was actually taking account of the total number of patient months for a given state for a given year by summing up over the product codes. So here it was basically which type of drug, how many months from the lot. So everything was taken into account, and that's how they came up with what was the patient month for a given state for a given year. And so they took for 3 months, 6 months duration, and 9-month duration. As I said earlier, that drop off of the patient keeps happening during the treatment course, and mostly the drop off happens in the first 3 months, and then if it is a long term um, treatment more than a 6 months, then drop off again happens at 6 months and 9 months. So whenever an individual is started feeling a little bit better, their fever reduces or their uh, other symptoms reduces, and they drop out of the treatment course. That was the thing. So therefore, we it in this research work, they tried to assess the patient months for 3 months duration, 6 months duration, and 9-month duration. And then they also tried to compare with the public sector, and these all numbers are per thousand. 315 per thousand kind of 315,000 this. So and in the bracket, these are the 95% in credible intervals, and we were able to see that there were certain states like Uttar Pradesh, UP, which has one of the highest burden state in India. Then and which was huge because this was 1/5 of the total national burden in the private sector hospitals. So this also helped to estimate. So this study helped to estimate the number of patients seeking care, TB care in the private hospitals. B, it also helped to understand or estimate the what is the burden in different states, which are the high burden states in terms of the people seeking care in the private hospitals. Um, and for the very first time, it gave the volume of patients which was missing out from the notification data. So when this as these estimates combined with the notification data, it gave a full picture of how much is the TB burden in the India across public and private sector. This also actually mm, uh, then this also pushed towards the policies where it was made mandatory to notify the patient seeking care in the private hospitals, that the doctor needs to be notified in the government portal that a TB patient is seeking care in the private hospital or in their hospital or in their clinic. There were also policies which were made to shift these um, these patients who were seeking care with the private practitioners or the small clinics, because to shift them to the government hospital so that they can have a better diagnostic facility, access to diagnostic facilities, and better availability of the treatment or the medicines throughout the treatment course. Yeah, um, so before that, yeah, so somewhere in 2017, the government order came that every private hospital has to notify any TB case which comes to seek care in them. And it made a huge impact because after 2017, the notification data kept on improving. You know, um, so those who were missing out from the notification data and the estimates of the correct estimates of the TB prevalence, this was a huge step by the government in terms of the policy. Um, this another piece which came out in BMC infectious disease in 2019. This was on the tuberculosis treatment in private healthcare sector in India, and this was again done with the uh, this analysis was done using the drug sales data. And in the left graph, if you see, this is the national level estimate of the public and private sector trends of the volume of the patients seeking care in the in either of the sector, public or private sector. And you can see that at the national level, the majority of a large proportion of TB individuals who were suffering from TB were seeking care in the private sector. Uh, and these numbers were in millions, so you can see that around about, but over the period from 2013 to 2016, as I said, that after post 2016 the government order came that they need to be notified, but before that you can understand this gap. So this was a huge gap which was not notified for all these years, and we did not had any understanding of the true burden of TB. Though the modeling studies were helping out in estimating the total burden of tuberculosis during that time, but again, we need to validate the modeling estimate as well. So this was something very much crucial um, in terms of the evidence validation and also in terms of the policy formulation. This work also said that India comprises of 24 different states, and some of the union territories. So you can see that one of the state, again UP, stands out, and it's one of the top 5 state, one of the topmost state, I would say, back then, where the TB burden was highest. Although the conditions have improved, and um, in UP in terms of the TB burden. But this was the work using the drug sales data, which was very, very important in terms of the understanding of the private healthcare sector prevalence of TB. Okay. So till now we were talking about the TB prevalence, which is prevalence is actually the total number of cases, they including the new infection cases as well. But in order to understand how our interventions are working, it is important to um, have the estimates of the new cases, which is incidence basically. So it is important to estimate the tuberculosis incidence. But how do we get a hold of this incidence number? Though we do have the data from the prevalence data, and also the other data or which was again coming from the primary survey, which was on the annual risk of TB infection. And so this was the work done by me back in 2014, 15, and we tried to see to estimate the incidence from the primary survey data. And as I said, that bifurcated healthcare system is one of the important attributes in the TB epidemiology in context of India. So for the transmission dynamic, I actually kept the model simple, but did I did not consider the healthcare sectors. However, since the data was available in terms of the smear positive cases and the smear negative cases. Now, what is a smear positive and smear negative disease? It is when the sputum is collected under the microscope, a smear test is done, and where the bacterial colonies is actually identified or quantified, I would say. Um, and based on this, the result says whether a person, whether this specimen is TB positive or not. So that is a smear positive. So number of individuals who are smear positive um, is the prevalence of a smear positive disease. Since the data that was available from the primary survey was in terms of the smear positive cases and the smear negative cases, we tried to bifurcate the active disease. So what is active disease? Where the TB in where the individuals are infectious and can spread the TB disease. When they have bacteria but in dormant state, and this is the latent infection, it is here in the latent phase, they do not spread the disease. They are not infectious, and they also does not feel any kind of symptoms. So yeah, and formulated into different a small transmission dynamics model, capturing the transmission dynamics of TB as such, where the important attributes were taken into account. For example, relapse is very important. Self-cure is also very important, though it's a very small proportion, but it is important. All those who does not receive treatment, sometimes they get self-cure, and this is the data which comes from the pre-chemotherapy era. So using all those data, we did that. From India, we had the data, as I said, from the primary survey of the prevalence of smear positive cases and the annual risk of TB infection. Now, this was actually the data which was, uh, these primary survey happened in India at 8 districts. So we have states, and states are divided into districts. Okay, so some of the districts were in North Zone, some in South Zone, some in East, and some in West. And then the data was collected, and um, it was, those district level prevalence was actually um, pooled for the geography as well, rural and urban um, population. And this was data which was available from these primary survey for the rural India and the urban India. And when pooled together, rural urban, it gave um, approximate national estimates as well. So we calibrated our model to this data, and we found uh, on calibration we estimated the transmission rate, that is number of TB infection per prevalent smear positive cases. We also estimated the duration of disease or infectiousness. And henceforth, once these were estimated, what was the incidence of actual smear positive TB cases by geography. And you can see, if you see this, these first two graph, number of TB infections per prevalent smear positive cases and the duration of infectiousness in the smear uh, uh, duration of infectiousness. So if you see this topmost left graph, and you see that in rural India, the number of TB infection were less as compared to the duration of the disease, right? If you compare rural and urban India in terms of the number of TB infections per prevalent cases, we see that in rural India it is less than the number of TB cases actually in the urban area. What is this suggesting? That there is large number of TB cases, or the transmission is actually higher in the urban India as compared to rural India. However, in the rural India, that the duration of disease or the person remaining infectious with TB is way longer as compared to the person living in the urban areas, urban cities, with the low, with the small duration of infectionness of around about 2 years. However, this was something around 3 or 4 years, and in urban areas it was less than 2 years, so somewhere around 1 year, which showed that since the urban areas, the healthcare facilities were many, so the access to those healthcare facilities were, or even the local doctors, the small clinics, the accessibility was way good in the urban area. So people, as soon as they start feeling some symptoms, within few days they were seeking care, and they were visiting the doctor. However, in the rural areas where there was lack of healthcare facilities, at times people were not seeking care, and hence the duration of the disease became longer. Although this also pointed out towards that transmission was very high in the urban area, which was true because for the work and other reasons, people migrate from rural area to the urban cities, and hence um, there are hot spots, or there are, overcrowding happens in certain areas of these cities where the because of the overcrowding the transmission becomes very high, right? However, in the rural areas, because the home and every individuals are living quite far apart, there's a lot of air ventilation keep happening within the houses, uh, and also outside the house. So that's the reason that the transmission was slow, uh, which pointed out that we need the policies which can address these gaps, depending upon the epidemiological difference, geography wise. And for the very first time in the National Strategic Plan for tuberculosis elimination, which came out in 2017, for the next, you know, uh, from 2017 to 2025, there was a specific guidelines that since the epidemiological difference between the rural and urban India was there, and for the TB epidemiology, the diversity of TB epidemiology in the country necessitate different approaches, which means that we need to adopt different approaches to tackle this gap. This gap where in the rural areas we need to uh, increase the accessibility to the healthcare facilities, and in the urban India we need to break down the transmission chain. So for the very first time, based on the this differentiated epidemiological TB epidemiology in rural and urban India, the policies were designed by the geography. Okay, so this is the recent article, and why I chose this uh, is because this is the work of the new based on the new diagnostic tool, and you may have heard about a lot of discussion is ongoing on the subclinical TB, right? And on the subclinical TB, there is a lot of ongoing thrust to diagnose the subclinical TB. What is subclinical TB? Actually, it is somewhere in between the latent and the active disease, right? It is, you can say it is just before the active disease, where the person start transmitting, not transmitting, I would say, where an individual start expose showing the symptoms, right? And where these symptoms are not being shown, and but it is actually quite near to this, at the stage where they will start showing the symptoms, and before that they are transmitting the TB bacteria. And though the transmission is low as compared to when the transmission happens during the symptomatic phase, uh, it is important to identify those subclinical TB cases. These are also known as bacteriologically positive. So that means they are not showing symptoms, but in the sputum examination, the bacterial load is high, and hence they are bacteriologically positive TB cases, which is, if not put on treatment, they will start showing the symptoms, as well as the percentage, or there will be increase in the transmission also, right? The transmissibility will increase, you can say. So if you see this left hand graph where A and B, you can see that out of the proportion of untreated tuberculosis, so uh, there is around about 60% of cases which are in the subclinical phase, where they do not show symptoms. That means they are not symptomatic. However, they do transmit the disease, right? Uh, there is a small proportion before they sought care. They are in this pre-seeking uh, phase, where uh, mm, identifying anyone in this phase is very important. Same goes with South Africa. Even in the South Africa, the proportion of untreated TB, there is a huge, round about 60% of these untreated TB cases are actually in the subclinical phase. And if they are diagnosed early, then since they are having low transmission rates, low transmissibility, if diagnosed early, the transmission can be reduced. And if the transmission is reduced, definitely it is going to have an impact on the TB burden. So as we are approaching 2030, the WHO and all the high burden countries, they are putting a thrust not only development of the new vaccine, but also finding out what are the ways in which we can prevent, the prevent, and we can treat the TB individuals in order to reduce the burden. So you can see that, so seeing this, so if you see here, if there is no intervention given, right, and compared with the different type of intervention is given, so this green uh, trajectory is showing if we are able to detect the 10% of these asymptomatic TB cases who are in the subclinical phase, who are clinically vulnerable. If it's done, there could be a small benefit in terms of averting the cumulative cases over a time, right? But if we, so this is the passive cases. This is not a passive cases. Actually, this is not a passive cases. They are house to house or some sort of intervention needs to be done. Uh, this is with just 10% of uh, active case finding. I would not say active case finding, but it's more of a proactive case finding actually before it becomes. But if this is increased, right? So if they become proactive cases finding, symptomatic tuberculosis is being found now. Here the symptoms have started appearing, but you know, um, uh, yeah. So these are the cases where symptoms are appeared and then they are actually finding out the TB cases. These people have not gone and seek care in the hospitals on them by themselves. Before that, they are being captured. But if there are new diagnostic in the healthcare facilities, which can diagnose even the people in the subclinical phase, that those who are asymptomatic cases, this can be reduce the burden. Everything combined, whether it's new diagnostics you are making available in the healthcare facility, which can detect the um, uh, subclinical TB, or if it is, the new diagnostic which is made available in all the public and private, both you are putting efforts. The intervention is also capturing the proactive or the people in the subclinical phase by going, say, by doing household surveys. So everything, so basically by all the means, if trying to capture or early diagnose the during the subclinical phase itself, the cumulative number of cases averted could be as high as 15% of cases that can be, um, uh, averted in India. And something similarly, even in South Africa, nearly 15% of cases of uh, TB, future TB cases could be averted. So this is important that we need to tackle the cases um, with different interventions. One intervention will not work. We need to reduce the diagnostic delay. We need to make sure that the treatment success is happening. We need to make sure that we are able to identify or diagnose the subclinical TB. Uh, we need to focus on the prevention of TB as well, whether it's through the vaccine or any other method. So all type of interventions are required to achieve the 2030 targets. Okay, so so this was all I was talking about the TB, because in India, TB program has taken modeling into consideration for a very long time in shaping their policies. However, in other infectious diseases or the NCDs, modeling has not played such a huge role like TB program. During the COVID-19 pandemic, as we were seeing that there was a lot of uh, hue and cry, and a lot of every government across the globe was taking help of modeling in defining or designing their policies. Indian government also took into consideration using the modeling and in fact, I will come to that later my next thought. This piece of work is actually from the Imperial College London, and where the COVID-19 task force was there, and they started generating the evidence on the COVID-19 pandemic as it was spreading in the UK. And during the March 2020 or very early, the stand of UK government was that the herd immunity will take care of everything. We don't have to do anything. Herd immunity, once maintained in the population, and um, the transmission will break, and yeah, COVID will go away. However, this early work by the Imperial team actually showed from the showed the results of these their epidemiological modeling, and uh, informed the policy making in the UK, and so they had this um, you know the forecast of the number of deaths that could happen per day per 100,000 population in the UK, and they also did for US, if nothing was done. Now, why they estimated the number of deaths per day? Because casualty is the important thing, or is the important measure or the indicator when we are tackling any outbreak or any pandemic like scenario, right? If the number of deaths are small, government don't bother. But if the number of deaths can be huge in the near future, the government they want to take all the measures. So this forecast from the Imperial team showed that if nothing is done, somewhere in the May and June only, we will have huge number of deaths. So nearly 20 per 100,000 population every day. Okay, and cumulative number can go around 500,000 of deaths. Um, they also showed that during that time there was not specific treatment available for the COVID-19. So so based on the information knowledge that was available on the during that time, depending which age group of the population was having the highest hit. That means which age group was having the highest COVID-19 deaths or the number of cases. So based on all those information, using the epidemiological modeling, it was identified that there can be different scenarios, and in these different scenarios, if you start with here, um, if you don't do anything, then there's a huge requirement of the critical care unit, critical care bed, um, uh, somewhere around for every 100,000 population, nearly 280 bed was required to provide the um, treatment whatsoever was available. If the schools and colleges and the universities and the offices were shut down, then it can be reduced further, but it was again huge. There was again the huge requirement of critical care beds. Mm, However, if the cases were isolated, that means if you can break the chain of transmission. So anyone who is identified with COVID-19 is isolated, quarantined and isolated. The chain can be traced back, and all the contacts can be again isolated, quarantined and isolated. That will have an impact in breaking the transmission chain, and that could reduce the transmission, and henceforth the requirement of severe of the critical care beds would reduce, because then there is a probability that the severe cases would also reduce. However, given everything, if the case identified is isolated, home quarantine of all the contacts was happening, and if elderly population was maintaining the physical distance, right? Back then it was, I think, 7 feet or something. But yeah, then it was reduced to 3 feet. So, and using of mask and all. So all these scenarios help to lay down that we need to do something. There needs to be certain intervention, may not be in terms of the vaccination because it was not available then, and not in terms of the treatment, but there are some non-pharmaceutical intervention that needs to be placed in order to, you know, go. So yeah, so this piece of work, it came out very much in the scientific Nature scientific reports, Nature as a special report, and where they said that um, for the very first time, the modeling has played a vital role in implementing a strategy of any government, where the government has taken a you know strict action based on the modeling um, very fast, very quickly. And based on this work, only the lockdown happened. India also used COVID-19 and modeling. And using the modeling, they tried to see, because in India as well, the lockdown happened from the early 2020 to mid 2020, and there was a lot of hue and cry from the various group of people who were saying that these imposition of immediate lockdown is not the uh, appropriate thing which was done by the government. So government has to tell them that in a quantified way, it may not be the best step, but what is being achieved. So during that time, modeling tried to see how many cases were averted, how many deaths were averted, and I looked into only the mortality data, and based on that, the different modeling teams had different, number of death averted data, but more or less, it's not the absolute number, but it is like there's a huge number of cases which were actually, a huge number of deaths which were actually averted. So this is something that, um, the COVID-19 also gave us the importance of including modeling in policy making. So post pandemic, there has been a lot of thrust from the government to build the capacity of uh, modeling, and or use the existing modeling capacity for various disease control programs. This is another example of using the modeling, and this is the important piece because the immunization program, as we know, that it exists in every country of the world, and so this was the WHO's expanded program on immunization, which was actually started in 1974, and they wanted to see what has been the impact over the 50 years of these globally. The immunization was for the measles, pertussis, tetanus, tuberculosis in the infants and the children, polio, etc. And you can see that uh, the number of deaths averted is huge, specifically from the measles and right. Even the life years gained from this immunization, especially from the measles, is preventing from the measles is around 9 billion across the globe, and so on. So, yeah, this is something that I want to talk about. To just to give you a quick glance, um, that during the COVID-19 pandemic, when modeling takes time, right? Modeling takes time in a way that even if you have existing model, if you have existing simulations ready, everything, you may take time for maybe 2 3 days at least to come up with the results and all. In the meantime, what can be another factors that how the analysis of the epidata can help. So this was some of the small work that I did during the COVID-19 pandemic for the WHO Southeast Asia region, and when I was leading the modeling for all the 11 Southeast Asian countries. This is the graph heat map for India only, and this is week by week analysis of all the 24 states of India. And you can see what I did was, so there's a case fatality rate. So people coming from the epidemiology background will definitely know what is case fatality rate. Cases per million, deaths per million, tests per billion. So these are the proportion essentially for any given proportion of, so say why per million? Because it, um, for every states, the population or the denominator is different. So in order to bring all the states at an equal level, the denominator needs to be, um, you know, standardized. So for that reason, the populations for all the states were actually, uh, all the cases per million was considered, deaths per million, um, um, tests per million, which were COVID-19 tests, which were happening, everything was considered. And what I did, this was a very simple analysis after taking these proportion for all the 24 states. So for example, for the case fatality rate, ranked these states based on the highest case fatality rate. So you can see here. So this is December 15 to 21, December 22, then January in this. So here you can see that this BR, this is the code for one of the state in India, Bihar, and here the case fatality rate was high, right? The highest most, and then these. So here is the rank from 0 to 24. The deep red color was the highest or topmost um, um, in that epidemiological indicator, and the light one is the lowest on that indicator. So you can see that this BR in terms of the case fatality rate, it's a kind of a temporal analysis or weekly analysis, which can tell you how your different states are performing based on the epidemiological indicators. So you can see that in the this first week, the this BR state was having the highest case fatality rate, which in the next one is brought down to 17, and then going to the next, it has reduced. So you can see and make sense that how and where the different states are performing on the epidemiological indicators. This is just for the quick analysis. So yeah, so that was the reason I wanted to show you. In order to summarize what I have spoken, I want to talk about what are the role and challenges of infectious disease modeling. So definitely with the infectious disease modeling, we get the clear understanding of the disease system. Um, we improve our understanding of infectious disease, right? We can do some projection, we can evaluate and compare the potential epidemiological and economic impact in terms of the interventions. We can drive research also, as I mentioned earlier. Um, we had the gene expert, but the modeling results showed that we need a this tool is very good, it's very beneficial, and we need some indigenous build so that we can reduce the cost of every test performed. So research will be driven by the modeling evidence generated. So basically it's a evidence-based decision making. Now, what are the complexity or what are the challenges? Modeling is good, but as it is being said, garbage in, garbage out. That means you need to have a clear understanding of the disease epidemiology. The model structure can be very complex, and having a clear understanding of the disease epidemiology, the data, what is your research question in hand, and how do you, what are the attributes of the disease epidemiology that needs to be captured in the model structure is very important, so that you do not make the model structure very complex if it is not required. If it is required, then you do have to you have to consider the complexity. But that clear thought process is needed. Uh, the uncertainty of model outputs. that is something very challenging. And what are the limitation of my data I should be aware of, so that I'm able to interpret my output in those lines, right? We need to keep um, have a better coordination with the um, uh, public health professionals or the stakeholders. Um, so they shouldn't be limited communication. The communication between the modelers and the different stakeholders, generally the public health people, the program people, so that what is their requirement, what is the data available, how it is being captured, all that information can be understood by the modeler. The model that has been prepared or made by the modeler can be understood by these public health professionals, and they can. So it's a back and forth communication. When this communication is good and everyone is on same page, the output generated from the modeling exercise is actually helpful and generates the evidence for their decision making. So we need to have a clear understanding what modeling can achieve, but at the same time, what are the challenges that I can face, and how should I overcome those challenges? Um, so as I said, um, it's so mathematical models are being developed and the public health practice for the public health practice, but there needs to be a constant communication between the different stakeholders, be it the modeler or the public health people or the policy people, the on-ground staff also, because the way the primary surveys are being, you know, captured, this also gives us insights about the population level things, and whether it can be captured in the model or not. That is something that modelers have to take call. But yeah, all that things are. So we all understand that there is a lot of relevance of disease modeling in the public health. It can inform the evidence-based decision making. We can predict and we can forecast disease burden, the impact of interventions, and all. We can identify what is the optimal use of limited resources, and hence the resource allocation can be done. uh, the estimation of disease burden is one of the um, important question that every where it is being done. Uh, Modeling can also help during the emergency situation, during the outbreaks. How do we prepare and how do we respond to those outbreaks? Um, we also in terms of the health technology assessment, so now availability of AI tools, we can see how so again modeling can come into picture in say how the new tools, say for example diagnostic AI tools, can be of use or of value in reducing the burden because of the early diagnosis of different disease and henceforth. So disease modeling have quite a relevance in terms of the public health scenario. Um, Before closing my talk, I would like to make one important, you know, um, suggestions or something that we need to, when we are making the model, we need to be built our model on the reality. What is the ground reality? We have to keep this in mind. And clear understanding of the data, the gaps, the uncertainty is very, very important, because if we do not have an understanding of our data, what is being plugged into, we cannot make any sense of the output. So it is much more important. Next important thing is that no model structure is good or it's, I would say not good. No model structure is correct or appropriate. We always adapt over time. So we keep on building upon it, right? I started with a small model. We keep on building the complexity, bringing in the complexity. Starting with a complex model may be challenging at times because of the availability or issuing the data. Research and implementation can be really bridged using these modeling techniques. Thank you very much for patiently listening. And if you have any questions, please uh, throw them. Yeah, you can ask.
Yeah, okay. Yeah, thank you very much, Suradi, for a very wonderful talk. That's very good. Thank you. So let's give a round of applause.
Very much. It was very
Yeah.
nice. And for the very first time, I was interacting with the African continent. I mean, I have interacted with many researchers from Africa, but in terms of the webinar, this was my first webinar in the continent, I would say. So thank you very much, Professor Bakare, for inviting me for this webinar.
So any question from any one of us? One. And then from the online participants, if you have questions, let's also indicate. And Deborah, then what? The question? Three. Okay. Question from the online participants. Anybody indicating for ask question? Okay. Yeah. So I will ask at the end of it.
Thank you very much, Dr. Andy. My question is, I noticed the figure 2. So I want to know how you quantify the close down of schools and university and other parameters that were scenario analysis that was verified too. I want to know how you quantify them. Do we have data for them? Hope you get my question.
You are asking about the data that is being used for the scenario analysis. Is that something?
Figure 2 plots. COVID-19.
For COVID-19, okay. So for the COVID-19 or for, in fact, for any of the disease, when the model is developed, taking into account the transmission dynamics of a disease. So I will give you one example. So currently I'm working on the vaccine impact modeling. There are new TB vaccines which are in the development and phase 3 clinical trial and may be available for the licensor by 2030. So government of India will also roll out as like any other country of the world among the adult population. Now, given the India is huge and diverse in terms of the geography, in terms of the population size as well, you all know. So it cannot be rolled out in one go. Now, what should be the strategy, optimize the strategy with which the population can be vaccinated for the maximum benefit. So for that, now we have developed a model. It's a complex model because we want to identify different strategies, whether we should look into the geography wise strategy, whether we should reach out to the urban population first or the rural population first, or we should reach out to the high risk groups such as the low BMI people, so people with undernutrition because of the BMI. They are more prone or at higher risk of getting TB. So in the model structure, we need to consider the general population and the people with the high risk of TB, such as low BMI people or the people with living with diabetes. We also have to see the if we are looking at the geography-wise strategies, so maybe capturing the geography as well. Now, since these vaccines will be rolled out among the adult population, and BCG vaccine is already being given to the neonatal. That means when the baby is born in the very first year. So we have to consider that vaccine also. Now the BCG vaccine, it gets the immunity gets has a waning effect. Um, it start waning after 10 years, and as soon as they achieve 14 or 15, there is no protection against TB. So even the vaccine, the existing vaccine efficacy or sorry, immunity, that needs to be captured in the model. The age structure needs to be captured in the model. So you have framed your model, you have built your model on all considering all these factors. Now, I want to see. So scenario analysis can happen in a way that if I am targeting, say, my 50% of the population over, say, 5 years of time, if I'm able to reach my population in next 5 years, 50% of population in next 5 years, um, in terms of the vaccination, new vaccine that is being given to the adult population, say 15 plus, because before 15 there is a BCG thing is there. So targeting 15 is the appropriate. So anyone with 15 plus age is receiving. So those kind of scenario analysis, uh, you make certain assumption. So if I'm, say, for example, so I'm making assumption that I'm going to the population coverage, the vaccine coverage will happen for 50% of population in the 5 years time, maybe in the linearly scaled way. So for the scenario analysis, you can make certain assumption. However, for the natural history, for the, say, here, for example, the waning immunity, for the risk groups, the relative risk of getting TB infection in comparison to the general population, all that comes from the data, and that data comes from the empirical studies. I hope I have made, I'm able to answer what the question was. Yes, please.
Okay,
Next question.
thank you very much for your response. Yeah, so I want to, okay, maybe I should settle the people here seated, and then I will come to the online participant. Yeah, number two.
Thank you very much, Dr. Andy, for the presentation. So, of course, we know that TB is a really contagious disease. So, from the presentation, I would want to know some of the factors, particularly when you speak on poverty and then related to TB. I want to know what are actually some of those factors that predisposes those in the poor region compared to those poverty compared to those that are well-to-do in India, and would this also be generalized to other locations? And also, we want to also ask on the gene expert diagnosis machine that you talked about, and we see from there that we have the impact more felt in the private sector compared to the public sector. So I want to know what are those things that the private sector are doing differently compared to the public sector that we have this machine having high impact compared to what we have in the public sector. So thank you.
Sorry, I could not get your last question. Could you drop in the chat box, or could you just repeat it again? What you were asking regarding the different healthcare sectors?
Yeah, so let me please quickly. So you talked about in the presentation that the gene expert diagnostic machine
Okay.
yes was more the impact was more felt when the 100 case, I think 100 case or thereabouts we have implemented in the private sector compared to the public sector. So I would like to know what exactly is the private sector doing differently that made that machine to have more impact in that sector compared to the public sector. Thank you.
Okay. So I think your question is for that rollout of gene expert machine and understanding the impact where it will have a higher impact of rolling out, whether it's a public sector or private sector. So there the model was built capturing the transmission dynamics in India. having a bifurcated healthcare sector. So there was people seeking, so a person get the infection, and after getting infected, they may go and seek care in the public sector or in the private sector. Now, in the public-private sector, so we need to have those compartments, public and private. So person can go to either public sector or private sector, or even if they are going to public sector government hospital clinics, they can come. They can uh, for the second opinion, you can say they can go to private clinics as well, and so in between is happening. Now, as an intervention, you can plug in the intervention in terms of the gene expert machine. So if gene expert machines are being rolled out in the public sector or in the private sector, right? This is also a scenario that you are trying to see. If all the 100 are being given in the public sector, that means you are decreasing the diagnosis delay. That means the diagnosis will happen early. If the diagnosis is happening early, so for example, in the very first visit, the person will be diagnosed. A person is diagnosed, then they are put on treatment. Now, assuming that the treatment is successfully completed by 75% of cases, right? Or 95% of cases. So ultimately, because it's a transmission that's being captured in your model, early diagnosis, early treatment start initiation, that means you're breaking the chain of transmission. So it should have impact on your prevalence also. So the outcome is measured in terms of what will be your um, how many cases will be averted in say next 2 years, 3 years, or 5 years of time period. Generally, 3 years or 5 years we look into. Okay. Similarly, scenario can be seen that if all the gene expert machines are rolled out here, so that means now the diagnostic rates are original rates for the government hospital, but for the private hospital, it may be reduced by say 10% or 15% of time. Treatment success rate is being maintained, and then what is going to happen? So does this answer your question?
Yeah, thank you. Thank you very much. Next question.
All right. All right, Dr. Pandi, thank you so much for again your presentation. All right. So the paper presented on estimating tuberculosis incidence from primary survey data, a mathematical modeling approach, is of interest to me because of the fact that we have to estimate the incidence from primary survey data, which was a prevalence data. I was interested in knowing how many data points the prevalence contained, the time, I mean the is it a monthly data set that was used or yearly data set that was used to estimate the incidence, and then considering that it is prevalence, so data that we have, I really want to see what was the technicality involved in being able to really derive that incidence from the prevalence data that we have using the model presented. Right. Thank you.
Yeah. Since TB is a long time disease, so it has been in the populations worldwide for very, very long, for not just for decade, for century, right? So since the data which was available to me for the prevalence data especially was for one single data point, though it was coming from 8 districts, but it was done in 1 year. So I had that data for one single year. Now for long-term diseases, we can adopt an approach of equilibrium modeling, right? So what it is that, and now if you see even the global trajectory or even for the country trajectory as well, the prevalence that which has increased over the decades has now stabilized, and now the curve is slowly bending, right? But it is somewhere in the equilibrium. So this equilibrium modeling approach is very much useful when you have a long-term disease like TB, and you have a single or one or two data point only. You don't have a time series data. So what happens is your prevalence has actually achieved equilibrium, and now at this equilibrium, because my data is, say for example, 300 per 100,000 population, right? That prevalence. It was around about 260. So when the model generated simulated result will hit that 260, it will estimate the transmission rate and the duration. And for that instance, that transmission rate and that duration will be um, estimated. With those estimates, we can infer the incidence. When you have a transmission, then the whole model can give you the data of on the incidence using the estimates which you have calibrated your model to your given data um, on the transmission rate and the duration of disease, and that those estimates helps you to further estimate the incidence. But it does not it's not applicable where the diseases are seasonal in nature, for example like malaria, dengue, etc. um, this equilibrium modeling approach is only helpful when your data is scarce, but also your disease cycle is very long. It's so conditions like TB, where it has been in the population for decades and decades and decades.
Thank you very much. Now, the online, I want to call on Marvelous Ogofota. Can you go ahead with your question? Marvelous Ogofota. Thank you.
Okay, thank you very much, Prof. And thank you, the presenter, for a well-presented webinar. So my question will be direct. I think in your slide, the first one was talking about poverty relating to tuberculosis. So my question will be, talking about that, why is the poor more vulnerable to contracting tuberculosis in India? And if it is so, why the what socioeconomic and health-related factor contribute to this risk? Then another question is, does the type of healthcare system, private or public, what role do they play? So that's my question. I don't know if you get it clearly.
So your last question on public and private, what it is?
Yes, what role do they play in all of this?
Okay. Please let me know if I have understood your question clearly. So you wanted to know about the public and private healthcare sector in India and how it is how the TB care is role. I mean, I'm sorry, I'm not able to understand your last question. Could you please repeat it again?
Okay, let me repeat again. Now, my question is being portrayed from the first point, so I will start again so I get the question clearly. Now, the first one is, it was known that the poor are more vulnerable to contracting tuberculosis in India. Now, the question that follows is, what socioeconomic and health-related factor contribute to this risk? Then beyond that, in the course of the webinar discussion, you made mention of both public and private healthcare system. What is their role in all of this?
What is?
What is the role of the private and public
Oh,
healthcare system
okay. Now I have
in
understood.
combating tuberculosis?
Okay, got it. Thank you so much for repeating. So, as far as the socio-economic factors are considered, uh, the economic strata populations, uh, given their living conditions, at times because of the poor air ventilation, the overcrowding, and sometimes these people are also the daily wages workers. So, uh, loss of wages is one of the factors in accessing the healthcare on time. So these are the socioeconomic barriers, I would say, challenges that these people have to, you know, break. Secondly, is because it's a low economic strata, so they generally they live in a overcrowded area, which becomes a hotspot for the transmission of the disease. And when they do not seek care on time, that drug susceptible TB can it is actually being found. The studies have been done, and it has been found that due to the delay in the diagnosis and the treatment initiation, the drug susceptible TB is actually now they get into the drug resistant TB and sometimes MDR TB. So if they are not being identified or diagnosed at the early stage, the chances of their cure and the treatment completion and the complete cure is one of the major factor. Second is also the relapse is very high in the first 2 years of the treatment completion. So anyone who has completed their treatment, they have to be very careful, and also the nutritional diet, the low BMI, and other comorbidities such as the diabetes. That diabetes burden is also high in India, and the smoking. These are certain risk factors which increases the risk of getting TB, and someone with these comorbidities having the TB will may even if they complete the treatment successfully, that means the full duration of treatment is completed, there is a higher chance of relapse among these vulnerable population in the first 2 years. So these are certain socio-economic factors which come into play. The government has implemented a lot of intervention. For example, one of the intervention I would say is one with a nutritional basket, or giving the direct benefit transfer of a certain amount of money to get a nutritional diet when someone is put on treatment. So this has improved the nutritional level in the in the individuals. Studies are being have shown. However, whatever is being done is there's a lot more needs to be done. So yeah, so we are trying to tackle the socioeconomic barriers, be it in the form of the different age groups. So men, as per due to the loss in the wages, they do not go on time, and hence the delay in diagnosis happen. So the government is trying to provide the healthcare facilities nearby. Also, there is a lot of drives which keep happening to find out the active cases. So active cases finding activities keep happening in the hotspot areas where the program itself goes to those communities. They with the um, diagnostic tools, they try to identify. Now we have AI tools as well to capture to screen the population. So it is by increasing the active case finding and putting them on treatment, maintaining the making sure that the treatment is completed. So these are uh, certain policies that I can tell you right now that are being there. On the terms of the public and private healthcare, bifurcated healthcare system, so as far as the big hospitals are considered, the treatment success is good there. However, for the private practitioners, small clinics, we also have doctors in small clinics. And now, so when we saw that there's a lot of missing cases, which is actually in the private sector. So government has initiated uh, programs or incentivization that if you identify, or if any TB if any person comes with presumptive TB, you have these diagnostic vouchers free of cost available. Send them to get the test done free of cost. And if they are diagnosed with the TB, make sure that they are being registered in the government hospital or where there can be. So those type of initiatives are being taken by the government of India. There has been a lot of thrust in the recent years, especially to bring down or to eliminate TB, I would say, though it's still ongoing. Every effort is ongoing, and we need to put more efforts. So now the vaccination is also one of the important preventive strategy or intervention that we are looking forward to reduce the impact. Yes. I hope I have answered, and if not, then please let me know.
Olatunbosun.
Thank you. Thank you very much. Yes, sir. Thank you, sir. Thank you, the presenter and the coordinator. My question is actually yes or no answer. I know that tuberculosis is a communicable disease. So essentially, to do primary survey, will it be compulsory to have medical experts to help to conduct the survey? And the second question is, will I have the opportunity to listen to this lecture again, because I have divided attention throughout? Thank you.
Yes, it's on YouTube. So the answer is so you go to our YouTube.
Come again.
So it's recorded. So go to our YouTube, you can check it. You can get it and listen to it again.
Oh, okay. I will need a link.
I don't know what is we'll say. Thank you. Over to you.
Second question.
I'll send. I'll get it. No,
The second question, please.
Okay.
Yes, for you. It's asking whether can they involve medical experts in collection.
No. I said, is it compulsory to have medical experts to help to collect primary data?
Oh, yes,
is it compulsory?
Yes.
Because
yes, it is. It is. So during the primary survey that is being conducted by the government agencies, say for example, Central TB Division and the Indian Council of Medical Research, they are planned activities, they are planned scientific studies, and in that medical doctors are there. Even when right now it's the chest X-ray are being read by AI tools, but previously when chest X-ray were read by the radiologist or the chest physicians itself, so 2 to 3 medical doctors were there. So throughout any of the empirical studies that is being planned, as per the requirement, medical doctors are uh, you know are involved throughout the course of the study.
Okay.
Without them, it is not possible to conduct these studies. They are crucial.
Thank you. Yeah, so I have some quick questions here. Now, based on the population of India and then the stratification.
I don't understand anything here.
That's not.
What does it mean by that? I don't know.
Yes, when we started, it was the same thing he said.
What does it mean by anything?
This person was not maybe an intruder.
Don't worry.
It's not for us. It may not be for
okay.
us.
Are you hearing me?
Or is there a discussion in between?
Can you hear me? Hello? Dr. Surabi, can you hear me? Dr. Pandey? Okay.
Yes, I can hear you. I can hear you.
So, based on the population of India,
yes,
and so I was thinking that because most of the models are being presented were actually based on like more or less like homogeneous system. So I was thinking that looking at apart from the one you talked about rural and urban settings, so which looks more like a meta population model. So I was thinking that like being able to target control intervention will not be good at if you look at age structure model and then and then um, um, looking at the high risk and the low risk group, because I found out that tuberculosis is a very, very dangerous disease in the sense that you could have it for several years and then you are just okay, you are not feeling any symptoms, and then you are spreading it underneath, and a lot of people are affected. So I think this is one thing for us to look at. And then another thing is also that some of the things you are doing in India on TB, I don't know whether you talked about national strategic plan for TB, but I don't know whether they have operational research agenda that involves modeling. Like in Nigeria, we have a National Malaria Control Program, and then the National Malaria Control Program is put together under the coordination of National Malaria Elimination Program. So the National Strategic Plan also have a part where they have operational research agenda, and in the research agenda, there are questions that are relevant to modeling that they want to answer. So which means that at the end of the day, we are not just we are not just doing academic models, we are more or less involved in operational models that can inform policy. So I think these are some of my concerns. Over. And then lastly, sorry, I think the other person was asking of the survey data. And then it piqued my interest in the sense that what's it called? When I looked at your scale, the horizontal scale, it was not over time, it was over space, like locations. I think rural and urban. So I don't know how you were able to use the prevalence data to do the estimation, and then so I will really lay some light in that aspect. Thank you.
Okay, I will go one by one. So, from my understanding, your question is India is a diverse and a huge is a diverse population with a huge size, and you were trying to say that in most of the models, it seems that it is a homogeneous mixing that I'm considering, and however, it may not be the case. Is that something that I've understood correctly?
Yeah, I said that apart from the rural, okay, the spatial one. So yeah, I've not seen one that talks about the demographic stuff,
Right. So, okay. So understood. So it always depends. So our model is never a homogeneous in nature. We do capture the heterogeneity, but or randomization, we do take it, and it is mostly captured in the parameter values because we consider not the point estimate, but the 95% CI for all the natural history parameters. And I can show you some examples from my work itself, if you want. So, for example, if it's a you know proportion of population seeking care in public sector. So it's not a point estimate of say 50% or 0.5. We will this is all informed data. Whatever in majority of the data is either coming from the empirical studies or the primary surveys, or it is from the secondary data analysis or the operation data research that is being conducted. Um, uh, so mostly the data is coming from the studies itself. Wherever it is not, we try to seek the expert opinion from the program itself, like Central TV Division, other researchers working over there. So the data itself captures the uncertainty. So the parameter values captures the uncertainty, and in that way, we consider the heterogeneity in our model, or the randomization in the population is being captured. A. B, we have the rural and urban. That was a differentiated geography data that was available because the survey was conducted at 8 sites, and some of the sites were falling under the rural setting, some were in the urban setting. So in that way, they of course did their analysis, statistical analysis. It's not the raw primary data that we use the secondary data actually from these primary surveys. So we work in collaboration with these program people. So so as I said, we work with in collaboration. We tell them what we need, what our requirement is, and based on the data available to them, they analyze it, they do some secondary data analysis, and then they give it to us. So in that way, the rural and urban data was provided to us. Now coming to that how I did that, it was a single data point. So as I have answered a previous question, for diseases like tuberculosis, specifically diseases like long-term disease like tuberculosis, which has been in the population for centuries and now have achieved the equilibrium level in India and even majority of the countries, the equilibrium modeling approach can be applied. So you simulate a model, say for prevalence, and for your prevalence trajectory is simulated, and that simulated trajectory, it is trying to, so your model is trying to calibrate to that data. So for whatever, and in the process they are I'm estimating there are other parameters for which I don't have the information. So for example, in the case where rural and urban data was used, I did not have any data on transmission rate and the duration of disease. So I was also calibrating these two parameter values. So for these parameter values, the model was calibrated. So prevalence, so for from the model, the prevalence trajectory was simulated. And when this prevalence trajectory was actually fitting, or, um, so if this is a data point and you have the trajectory coming in, so they can be this scenario, so for different beta values, for different duration of disease, you can have different trajectories. And for whichever trajectory, if it is being hit, then for the beta value and the duration of disease, uh, uh, these beta and duration parameters are actual parameters which are for which fit to the given data, right? Rural and urban India. And once we have the information, or we have estimates of duration and the transmission rate, we plug in back to the model and we estimate the incidence rates. That's how it is being the estimation happens. the model that I showed was simple because the idea was to only estimate the incidence from the primary survey data. However, depending upon the research question, as I explained that the current vaccine impact modeling that I'm doing, it is very complex model, nearly of 360 equations, where I have to consider the general population bifurcated by, the age structure, child, adult population, the vaccine status, vaccinated at the neonatal age, then the vaccine wane off happens, and then a complete loss of immunity due to vaccine happens as they attain 15 years of age. We are also looking at different geographies, so we are capturing the urban and rural in the model structure. So all the populations, uninfected, infected, latent, every compartment is having multiple layers in it. So the complexity of the model depends upon your research question that you are looking at. We need not have to look into all, we do not have to capture the complexity all the time. It depends upon your research question, and based on your research question, you consider the complexity that needs to be really captured, or you can ignore. So those are the choices that we have to make. Yeah. Any other question that you had? I'm sorry, I may have forgotten. Or have I?
All your comments and your response. We really appreciate your time, and we hope to have you some other time. I believe you will be ready to give another presentation. Thank you very much. Let's give a round of applause.
Thank you very much. Thank you everyone for listening, and it has been like quite long, 2 hours, and patiently listening, and very interactive question and answer session. Thank you very much. Yeah. So, okay. Yeah.
Okay, thank you.
Thank
Bye-bye.
you. Bye-bye. Bye-bye.
See you.